then I think we can start over because it's already, you know,
তুই আগে একটা কাজ কর, সেটা আমাকে মানে যারা যারা ইয়েতে প্যানেলিস্টে আছে তাদের সবাইকে ইয়েতে কনভার্ট করাবে কো-হোস্টে।
হ্যালো,
শোনা যাচ্ছে?
হ্যাঁ হ্যাঁ শোনা যাচ্ছে, শোনা যাচ্ছে।
ওকে ওকে ওকে,
আপনি একবার স্লাইড শেয়ার করে নেবেন।
ওকে ওকে ওকে, অ্যাকচুয়ালি আই ওয়াজ ওয়েটিং ফর আ লং লং টাইম।
ওহ, এক্ষুনি শুরু করে দিচ্ছি। অনুপম,
নো
হ্যালো।
প্রবলেম।
তন্ময়, হ্যালো।
ইয়েস,
হ্যাঁ আমার মনে হয় আমরা স্টার্ট করতে পারি এবারে, অলমোস্ট 7:10 বাজে।
so good evening everybody. This is the module 6 AROI West Bengal Clinical Oncology online course 2021. So today is the day 1 for gastrointestinal cancers. So I'd request Dr. Biprodas Roy, who is a GI hepatobiliary oncosurgeon of TMC Kolkata. Sir, can we start on with your class, sir?
Okay, actually I don't know means whether I am audible or I am visible anywhere. Can anybody see me or only the slides are coming? I don't know.
So the slides are coming.
Yeah.
So I don't need to look about my position with the camera, na?
No,
Sir,
no.
you are audible. You are audible, and your slides are visible.
Okay, thank you. So this class is for mainly the postgraduate trainee as an educational class, if I am not wrong. Hello?
Yes, sir. Yes, sir. You are right. Yes.
Okay. So actually, I have been given a very difficult task to finish a vast topic within a span of 40 minutes. Honestly, so I have been given an option of giving esophagogastric malignancy with special emphasis on gastroesophageal junction. So it's a 3 different body cavity, 2 different body cavity, 3 different structures, 3 different oncological outcome and their and in number of approach. But still I will try to give a basic idea. You know, I think as a postgraduate trainee, they know better than anybody else about the theoretical part, but what they should know about the practical implication and practical application of those knowledge into a clinical practice. So let us start with the discussion about the esophagus cancer.
Sir, may I interrupt, sir? Can you just start the slideshow? That will increase the screen size.
Okay. Is it okay now?
Yeah. Yes, thank you.
So means before knowing about the detail about esophageal cancer and their management all, so we should know about the basic landmarks, which is very important about the decision making, about the assessing the patient and their future planning. Few landmarks like where esophagus starts, like pharyngoesophageal junction is 15 centimeter, sternal notch is at the level of 20 centimeter, and all this distance calculated from the incisor tip. So and the azygous vein is around 25 centimeter, inferior pulmonary vein 30 centimeter, and the G-junction. Now question is why these numbers are very important, because if the patient comes with a locally advanced disease with endoscopic findings of distance of the tumor, so as a just seeing the esophagus, just seeing the endoscopy report, we can have some idea what are the structures are involved surroundings and what are the things we should be aware of. So the accordingly that and this G-junction we need a separate discussion. And that HSCC 8 has a separate definition of the G-junction will come later. Now, if you see that latest HSCC 8, they have divided into esophagus into cervical, thoracic, and abdominal part. So, and these are the distance. The basic distance we should know about the starting of the esophagus, that is 15 centimeter. And the 20 centimeter mark is very important for the surgeons, and definitely for the treating clinical oncologist as well, because proximal to 20 centimeter tumor, usually surgery do not happen in those group of patients. Why that it does not happen? Because for esophagus cancer, you need at least 5 centimeter proximal margin to achieve an oncologically safe margin. So if esophagus is starting at 15 and tumor is at less than 20 centimeter, we cannot achieve a negative margin in this group of patients. So cervical esophagus, we cannot achieve a surgical clearance. So these are the group is predominantly for the radiation and the clinical oncology part. So these numbers is very important. So the anatomical, if we see an endoscopy report, while doing an endoscopy, what are the important landmarks we see from inside the esophagus? First is that pharyngoesophageal junction, 15 centimeter. First indentation comes into the esophagus, which is visible. This is the aorta at the level of 22 centimeter. Left mainstem bronchus comes around 27 centimeter. This is a very, very important structure while we are dealing with a mid-esophageal cancer, which is little beyond the, which is little bulky, which have the relation with the left stem bronchus is obliterated. We should be very, very careful while dealing this group of patients. And the next important thing we see in endoscope is the diaphragmatic pinch, where the diaphragm starts and the esophagus passes through the diaphragm, and the last thing is the J line. So these are the structures normally an endoscopist, digestive disease people see while they are doing an endoscope. So while we deal a patient of esophagus malignancy, we should, three important structures come to your mind. One is that something is called mesoesophagus. Actually, if you have an argument with the anatomical people from the anatomic background, they will never agree that there is an mesoesophagus exists. But if you see that embryology of the esophageal development, you know, the digestive tube divided into foregut, midgut, hindgut, and during the development process, these three structures are connected with the posterior abdominal wall with multiple vascular channels. Now, during the process of development, different part of the gut lengthens different way. So midgut and hindgut elongation is more, and these structures then the connection between the posterior abdominal wall contains the vessel, it forms the mesentery. In case of hindgut, in rectum, it forms the mesorectum. But definitely that means if there is a mesentery in midgut, if there is a mesorectum in the rectum, hindgut, so there has to be a mesoesophagus in foregut. So what exactly that mesoesophagus is? That mesoesophagus is that lymphatic bearing fiber fatty tissue surrounding the esophagus. Why this mesoesophagus is important? Because just like a rectal cancer, if the tumor is bulky and if the tumor comes and the tumor margin reaches up to the margin of the mesoesophagus and that margin comes positive, that actually gives a bad prognostic factor in case of esophageal malignancy. And depending on this mesoesophagus and the lymph node bearing tissue, two basic principles of surgery depends. You know, there is something is called transthoracic esophagectomy and something is called transhiatal esophagectomy. The basic principle of transhiatal esophagectomy, it leaves behind the mesoesophagus and lymph node bearing tissue. It only take out the esophageal tube. So this is, from this picture is very clear that this is not oncologically recommended operation, and this is not an onco, means this, there is no role of transhiatal esophagectomy in esophageal cancer. On the other hand, in transthoracic esophagectomy, we take out the entire means lymph node bearing tissue along with the lymph nodes. So the principle of surgery is totally depend on this fiber fatty tissue called mesoesophagus. So there is a mesoesophagus exists in human body, It may not have a defined anatomical landmark or defined vascular landmark, but its oncological importance is there. Next important structure is the lymphatics. The lymphatics, if you see the lymphatic distribution of the esophagus, there are two kinds of lymphatic distribution. One is longitudinal distribution along the mucosa and submucosal level, and another is the the structures which pierce the muscle layer and drains into the thoracic duct. So that esophageal lymph nodes can go both longitudinally as well as radially. That is the reason you can have a skip metastasis in the lymph node away from the original tumor. If you see muscularis mucosa layer is very, very rich with the longitudinal connection of the lymphatics, and this is the reason behind the skip metastasis of the esophageal skip nodal metastasis of the esophagus cancer. So this because of this because of rich mucosal and submucosal lymphatics, the esophagus cancer can spread upward, can spread downward, can spread radially. Depending on the tumor location, the percentage of lymph nodes, the probability of lymph node spread to the up or down depends. But roughly, an upper thoracic esophageal cancer has a tendency to grow towards neck. A mid esophageal cancer can go in both the direction. The lower esophageal cancer can go predominantly goes to the abdominal lymphatic direction. And because of this rich submucosal lymphatics, even in early esophageal cancer like T1A, T1B esophageal cancer, you can have a node positive disease. That is why the exact nodal estimation or nodal treatment is very, very important in esophageal cancer. And this is just a number. This is just a percentage of or the probability of having lymph node metastasis according to the location of the tumor. If you have an upper thoracic tumor, it predominantly goes to the neck. If the lower thoracic tumor, it predominantly goes to the perigastric lymph nodal vesicle. So while we deal with the esophageal cancer, be it a surgeon, be it a clinical oncologist like you guys, if you see an endoscopy report, these are the important findings has to be there in an endoscopy report. First of all, how the tumor looks, whether the endoscopist can see the tumor properly, because most of the time, if the tumor is obstructed, lot of footballers get stuck with the tumor. So if endoscopist is not confident enough, they may not differentiate between a footballers and a tumor covered with the slough. So exact look of the growth is very, very important. Then the condition of the proximal mucosa, because in many conditions, especially in Barrett's or adenocarcinoma of the esophagus, which is predominant in the Western country, the proximal mucosa can have a skip lesion. Main tumor may be well below, but the proximal mucosa can have a skip ulcers, and that has to be keep in mind while dealing with or while treating, especially operating this group of patients. Then the location, the stricture, where the scope is going beyond, whether it's whether we can see the extent of the disease, and the condition of the stomach. It's very, very important, because if there is any lesion below, our surgical plan will be different, treatment plan will be different. Now, a patient comes with an esophageal cancer. These are the most important issue comes to our mind while dealing with the patient of esophageal cancer. First and foremost important thing is the nutrition. In almost all esophageal cancer, if they are not in an early stage without detected incidentally, all patient comes with some sort of nutritional compromise. So nutritional management is very, very important in case of esophageal cancer, because if the patient is not rehabilitated well with nutrition and and pulmonary function, patient will not be able to tolerate the entire course of the treatment, be it a radiotherapy, be it a chemotherapy or a surgery. So the nutrition is the most important part, initial part while dealing with the esophageal cancer. Now, what kind of nutrition is, whether enteral nutrition or parenteral nutrition? So if everything has to be an evidence. So there was this man, this is the this Japanese man has done an RCT on a patient who are going for a radical CTRT for esophageal cancer. They have given an enteral as well as few group was given enteral and parenteral nutrition separately. So they have shown patient with an enteral feeding have an advantage over the parenteral nutrition because they have a less hematological toxicity during the course of the treatment. And definitely parenteral nutrition is costly, more prone to have infection. So the enteral nutrition is very, very important compared to the parenteral nutrition. Now, how to give nutrition? Enteral nutrition can be given by nasogastric tubing, by feeding jejunostomy, or after stenting. So, which is preferable while dealing with a patient while treating a patient of esophageal cancer? If you ask me personally, if I am planning to operate a patient in future after giving neoadjuvant chemotherapy, radiotherapy, or whatever, some sort of neoadjuvant treatment, I would like to prefer giving a nasogastric, putting a nasogastric tube and optimize the patient. Because post-stenting, post-stenting patient, if the patient gets radiotherapy, there is lot of reaction surrounding the structures. So it makes the surgeon's life very, very difficult. So being a surgeon, I will prefer to put a nasogastric tube to feed the patient properly, to build up the nutrition, then patient take the all neoadjuvant treatment, and then I will prefer to operate on the proper time. Now, if the patient is not a candidate for surgery, if the patient is not a candidate for any curative options, in that case, self-expanding metallic stent is preferable if it's possible, if it can be placed safely. But the issue is, if the tumor is located in the lower third of the esophagus, in that case, stent placement is very difficult because the lower end of the stent will hang in the stomach. So this stent will not stay stay in position for long time. So one thing is very, very important is the nutrition. The next important thing is the staging. How to stage this group of patients. So we can have a PET scan and CT scan. Now, what is the evidence and what is the preference to do there? So if you, for esophageal cancer, PET scan is preferable over the contrast in a CT scan. PET scan has higher yield to detect any distant mets, because esophageal cancer is notorious to have a distant mets like bone mets, which is far away from the original treatment field. So, and there is one publication from Tata Mumbai also. They have shown the lymph nodal yield in PET scan is almost 10 to 15% more compared to the CT scan. But so in our hospital, we prefer to do a PET scan for a staging of the esophageal cancer patient. Now, another important component is the pulmonary optimization. This group of patients have some sort of pulmonary problems, especially related to aspiration. Because if the tumor is a patient is having an obstructive lesion, they always have some chronic aspiration in the form of pneumonia, and their lung condition usually stay compromised at the time of diagnosis. So the pulmonary optimization, taking opinion from the respiratory medicine guy, and starting proper physiotherapy and breathing exercise from the day one is actually improves the outcome after surgery and outcome after the treatment. Now, once everything is done, then we have to plan for the treatment. As I told you earlier, cervical esophagus surgeons has a little role. Tumor less than 20 centimeter distance, main treatment will be the radical Ctrt. No surgical option for those group of patients. But as per the AJCC 8, this group of patients should be treated as an esophageal cancer patient, not like an head and neck malignancy, because although the tumor lies in the neck, but does not mean they behave like a head and neck cancer. Next important part comes as for the management of esophageal cancer is the role of neoadjuvant chemoradiotherapy. After the publication of this cross trial in 2012, the management actually for the esophageal cancer has changed significantly. Tata Medical Center is one of the center who has adopted this cross protocol from the very early stage of their publication. Means we have started following the cross protocol from 2012, immediately after its publication. So what is the cross protocol has shown? It has shown benefit if the patient received neoadjuvant chemoradiotherapy, then followed by surgery, their median survival actually improves. But honestly, in this era, in 2020-21, no trial is possible with an arm where only surgery will be offered. So this kind of trial is not possible nowadays. So you have to add some sort of adjuvant, compare with some adjuvant or neoadjuvant treatment. So what was the findings of the cross trial? They have shown all group of patient has shown a benefit, but the patient with a squamous cell cancer has shown more beneficial compared to the adenocarcinoma. But one information about this cross trial which we follow is that although squamous cell cancer has group patient shows more benefit, but those patients with in this trial, around 75% patient was having an adenocarcinoma, and they have included tumor of G-Junction, Ctrt tumor, lower end of esophagus, adenosquamous both. So it's not that adeno does not respond to chemoradiotherapy, but squamous respond more than adeno. Now, so this was the conclusion. Now another important component is that another important proponent who favors neoadjuvant chemotherapy, they follow the original British trial called OEO2 trial, where they have given 2 cycles of neoadjuvant chemotherapy, cisplatin and 5-FU, and then they have operated, and they have shown neoadjuvant chemotherapy group has shown a survival benefit. In fact, many centers, including Tata Mumbai, they still follow this OEO2 trial in different form. They give neoadjuvant chemotherapy and then operate. But it depends on the institutional protocol. It depends on the whether surgeons are very or comfortable to operate after radiotherapy. Now, when to operate after giving neoadjuvant treatment? In case of cross trial, we normally wait for 6 to 8 weeks. We reassess the patient, then we take the patient for theatre. In case of neoadjuvant chemotherapy, like any other neoadjuvant chemotherapy, you have to wait at least 3 to 4 weeks before taking the patient to theatre. Now, so whether to do transhiatal esophagectomy or transthoracic esophagectomy. As I told you earlier, transhiatal is not indicated for oncological good oncological outcome. Transhiatal is only done where transthoracic esophagectomy is not possible. So now there is 2 main kind of operation happens in esophagus. One is Machion surgery. Machion is a 3-stage surgery. 3-stage surgery, there will be a three incision, 1 incision in esophagus, 1 incision in stomach, another incision in chest, and anastomosis is in the neck. So that is why it's called 3-stage surgery. The another operation is the Ivar-Louis, that is two-stage esophagectomy. Here there are two anastomosis. There is two incision. One is abdominal incision, another is thoracic incision. Now, which patient will do transthoracic esophagectomy? Which patient will do Ivar-Louis esophagectomy? Which patient will do Macion or three-stage operation with neck anastomosis? If you see the recommendation, surgical recommendation for the esophageal cancer, if you can achieve 5 centimeter proximal margin, in that is adequate for oncologically safe margin. Now that means in Ivar-Louis esophagectomy, our anastomosis lies around the level of agaricus vein, which is around 25 centimeter. So any tumor below 30 centimeter or the lower third of the esophagus or G-Junction area, we can do Ivar-Louis esophagectomy after neoadjuvant treatment. So this is the basic difference. Any tumor in the mid-thoracic esophagus or the upper thoracic esophagus, the anastomosis has to be in the neck. So in that case, we have to do a three-stage lymphadenectomy. Now the question comes: two-field or three-field lymph node dissection. As I told you earlier, esophagus is a structure which covers three different domains. It starts in the neck, goes through the chest, and ends in the abdomen. So it has connection with three different body cavity. So the tumor in the mid-thoracic esophagus can go in both the direction. The tumor in the lower thoracic esophagus mainly goes to the abdomen, and the upper thoracic esophagus definitely goes to the neck. Now, which lymph node to be, which protocol to be followed? If you see the Japanese guideline, they always prefer three-field lymph node dissection for upper thoracic and mid-thoracic esophagus in esophageal squamous cell cancer. But one thing about the three-field lymph node dissection, this is extremely morbid procedures. The post-op outcome is really guarded if it's not done in a proper hand. So what we follow in our center, that if patient is having any clinically detectable lymph node in the neck, before starting treatment, in those group of patient only we consider three-field lymph node dissection. Otherwise, we prove that there is a neck node in PET scan or clinically we prove that there is a disease, and then only in those group of patient we consider three-field lymph node dissection. Otherwise, we consider two-fold lymph node dissection in our hospital. Now it depends on surgeon's expertise and surgeon's comfortability about the treatment, about the operative procedures. So if we brief the treatment of esophageal cancer, the nutrition is the very important component to optimize the patient. Proper staging in the form of scanning, optimization, pulmonary optimization, in proper neoadjuvant treatment, and definitely surgery is the most important prognostic factor, proper surgery. Next topic, if anybody has any queries, I'll be happy to take that question now or later. But I'll move on to the management of gastric cancer. While if we treat a patient of gastric cancer, we should remember the famous quote of Lord Moynihan, that surgery of the cancer is not the surgery of the organ, it's the surgery of the lymphatic system. Because the secret lies in the dealing with the lymph nodes, especially in case of gastric cancer, which is applicable the most. Now, why gastric cancer is so important? Why the lymph nodes are so important in gastric cancer? If you see, gastric stomach has a very rich vascular supply and lymphatic supply. There are 4 different arteries which supply the stomach. So that means 4 different regions where that lymph node can different pathways where the lymph node can escape from the stomach wall if there is a stomach lesion. And Japanese, they have pioneered this. They have pioneered the concept of the different stations of lymph node. These are the different group of lymph nodes, which is technically is basically a surgeon domain. But we should know about means which group of patient needs what kind of operation. You know, so the concept, so the most important thing we should know about the exact type of operation which is required for a gastric cancer. D, which means, you know, D stands for the dimension of the lymph node dissection. If you see this graph, D1 group of lymph nodes always stays with the stomach. That means if you do a simple gastrectomy without thinking about the lymph node, by default you will take out the lymph node, D1 stations of lymph node. Now, if you take lymph node, if you go at the origin of those vessels, then you will take out the D2 lymph node, and if you go beyond the gastric field or the gastric supracolic compartment, then only we will consider taking out the D3. So why this D1, D2, D3 is important? There is a publication from the Japanese. They have given their data up to 1200 patients. They have shown if there is a metastasis in group 1 node, there is 47% chance the patient will have a mets in the D2 group of lymph node. So the proper staging is very proper lymph nodal clearance is the key for management of gastric cancer. The same study, they have collected the data of 6-7 years of more than 1200 patients, and they have shown if there is there is more 3 to 6 node positive, chance of having in D2 is 30%. If more than 10 node positive in D1 group, 80% chance they will have harbor mates in the D2 group. So D2 is the standard of surgery, standard which has to be maintained while operating a gastric cancer. Now, but the problem with that Western people is that they are always very critical. They have criticized Japanese data as a retrospective study because they have collected the data from their registry and there was no randomized control trial. So they want to prove whether actually D2 helps. So this is the largest trial, you know, this is one of the pioneer trial, Dutch gastric cancer trial, to prove whether D2 surgery has any benefit in case of gastric cancer. So initial assessment, they have seen the D2 gastrectomy actually associated with more morbidity, but not much difference. But in the initial, in 11 years follow-up, they have seen the patients with the node positive disease, they actually benefited from D2 disease. Now they have done an analysis after 15 years. So same analysis after 15 years, they have seen those patients who are actually alive, all those group actually received D2 surgery. That means the death due to gastric cancer is less if the patient receive a D2 gastrectomy. So they have published in 2010 and they concluded that D2 gastrectomy is helpful for a long-term survival if the patient having a node positive disease, but it has a higher morbidity. Now, again, you have to balance between the risk and benefit. So what are the risk and benefit? So these are the largest number, there is a various number of series of about the D2 gastrectomy, and they have shown like mortality 6%, 4%, 10%, even Kushiri have a mortality of 13%. Then again, one of the pioneer Japanese came with his publication in 2002. Professor Sano came up with 1,000 patient analysis and he had a 0 mortality. So he has concluded that so D2 gastrectomy is absolutely safe and sound procedure for management, and this is the only procedure for the gastric cancer. Now, if we have a D2, why not D3? So what is the basis of D3? The hypothesis of D3 dissection is that if the patient is having a D2, if the D2 lymph nodal basin has tumor in it, then there is a chance, 10 to 30% chance that there will be a micrometastasis in D3 lymph node. D3 means that para-aortic group of lymph nodes. So whether that group of lymph node dissection actually helps. Again, this same RCT, say again that RCT came from the Japan. This called Sasako. They have shown D2 and D3 actually there is no difference in 5-year survival. So D3 is not recommended. The standard operation is D2 gastrectomy in case of gastric cancer. Now, another important and technical argument about whether to do splenectomy routinely if we do a D2 gastric cancer. Again, the answer was given by the same person called Sano. He has come up with his publication in 2017 with a spleen preserving surgery versus splenectomy, and they have shown there is no survival benefit in case of if we do splenectomy. But there is a but they have done a subset analysis, and it has shown if the tumor is located in the greater curvature or in the fundus of the stomach, in those group of patients, splenectomy actually helps. So the recommendation and the principle of gastric cancer management is, if the patient is having a greater curvature stomach tumor or the fundus tumor, then only the splenectomy is recommended. Otherwise, splenectomy is not recommended routinely. Shivraj called me after some time. I'm in a meeting. Sorry. So next, so how we dissect the patient means, the various station. In our practice, we take out each and every group of lymph node separately, and we send those specimens in a separate container. So by the way, we can see, we can have an idea in which group actually tumor has have a metastasis. And if you send specimen like this, you can see the result, like, you have a station 1 lymph node, 4, station 2 lymph node. It's just an example how a proper histopathology should be in case of gastric cancer. You should have a separate lymph nodal basin dissection. Ideally, this should be done by the surgeon, not by the pathologist. Now, being a clinician, what should be the expectation from an endoscopist? So, if a patient of gastric cancer come to a clinician, so these are the important information has to be there about the type of lesion, and depending on this type of lesion, the patient treatment plan differs. So an endoscopist should, a proper endoscopy should have a mention about the exact location of the tumor, about the macroscopic type of the tumor, and that whether endoscope is passing through the antrum. That means whether the patient is developing any outlet obstruction or not. Why this tumor type is important? Because depending on this tumor type, the proximal resection margin during the operation determines.
Sir, sorry for interrupting, sir.
Hello?
Yes, sir, sorry for interrupting. Can we wrap up this class within another 5 minutes or so?
Okay, no problem. Another 5 minutes, I'll just finish.
Thank you very much.
So, as per the Japanese classification, type 1 and type 2 lesion, we need a 3 centimeter margin. Type 3, type 4 lesion, we need a 5 centimeter margin. Now, about the staging, what is the recommendation? CT thorax, abdomen, or a PET scan? Again, the evidence is the CT thorax and abdomen is the investigation of choice for the gastric cancer. What is the evidence? Korean studies, they show they do not prefer the PET scan. Japanese does not recommend any PET scan for the gastric cancer. UK people do the PET scan for the G-Junction and the lower end of esophageal tumor. NCCN, being the American, they always prefer the PET scan over the gastric cancer, for gastric cancer management. In our center, Tata Medical Center, we don't do PET scan for evaluation of gastric cancer. Against the importance of staging laparoscopy and peritoneal cytology. As per the AJCC 7 and AJCC 8, peritoneal cytology is considered to be a metastatic disease. Now, the perioperative management. Perioperative management is an important part of the gastric cancer. It depends on which continent you belong. Suppose if I am from European country, I'll get a perioperative chemotherapy. If I am from Asian country, especially the Korea and Japan, I'll probably go ahead with an adjuvant treatment. And if I am from USA, I may get radiation after the operation. But what are the recommendations and what are the principles why neoadjuvant treatment is important? Neoadjuvant treatment is important to downsize the disease. It has been seen that around 30% of the patient cannot tolerate chemotherapy after the operation. So better to give a systemic therapy before operation and then operate so that we can cover those 30% group of patients. So there comes the importance of perioperative chemotherapy. We all know the MAGIC trial, which shows the preoperative and postoperative 3 cycles of chemotherapy, which has shown survival benefit. But it has its own fallacy. The recent presentation about the new drug in the new modality is that the perioperative FLOT, which we follow in our center. We give 4 cycles of chemotherapy before surgery, 4 cycles of chemotherapy after surgery. Again, FLOT has come up with a publication last year, and they have shown tremendous result. Now, if the patient, another important trial is the Korean trial. So it has shown if we give adjuvant capox after D2 gastrectomy, it has benefit. Now, whether there is any role of adjuvant radiotherapy, if you follow the ARTIST trial, after the ARTIST trial result came last year, it has shown there is no benefit of adjuvant chemoradiotherapy. So the idea is to give either perioperative chemotherapy or adjuvant chemotherapy as per the classic trial. Now, another very practical point I would like to mention before I conclude: if the patient comes with a resection margin positive and patient has been referred to a clinical oncologist, what should be his recommendation? The evidence is that there was a publication in 2007 from Korea. It has shown that if the patient is having a node positive disease, but margin positivity does not change anything. Anyway, patient is going to recur in system. But if the patient is having a node negative disease, then there is a role of re-resection if the surgeon is comfortable with. Again, before I conclude about that, any kind of operation, biology is the king, selection is the queen, and we are just a technician just to change how to prevent the king for a long time. Now, I will not touch the esophagogastric junction, but one practical thing I would like to mention, especially for the postgraduate students. Everything is theory, but in real life, it means one size does not fit all. It's not that in every patient you will be able to give FLOT. In every patient you will be able to follow proper guideline. In a country like India, there is no control on the health system. During the practice, you guys will get many patients after an inadequate operation. In that case, the role of radiotherapy will come. If the patient is having a proper operation but without any perioperative chemotherapy and patient referred to a clinical oncologist, then try to follow the classic trial and give adjuvant chemotherapy. If there is a good communication between the treating surgeon and the clinical oncologist, then we can consider about the perioperative chemotherapy judiciously so that we can give a maximum result. And so the take-home message should be, we have to have our own strategy depending on the place we are working, but we should have knowledge about the basic evidence-based knowledge about the particular disease. Especially esophagus and gastric cancer outcome is very, very poor. It's a very aggressive disease. So in this aggressive, for this aggressive cancer, we really need aggressive treatment. So we have to have a proper knowledge while dealing with this group of patients. Thank you.
Thank you, sir. Thank you very much. At this time constraint, you have delivered an excellent lecture. So I would request Dr. Tapesh Bhattacharya, consultant radiation oncologist for TMC Kolkata, to give the next class. Dr. Tapesh Bhattacharya, please.
Yeah, thank you very much for giving me this wonderful opportunity. Can you hear me anyway?
হ্যাঁ তপস দা শুনতে পাচ্ছি।
Okay.
Yes, you are audible.
So just I want to share my screen once.
Okay.
Topesh da, Anupam here.
Yeah.
Before you start off, I'll just make one small announcement that to all the attendees who are attending the lectures, you can please keep typing your questions in the chat box, and our panelists from time to time will be answering them. And after that, again, at the end of all the 3 lectures, we'll be having a Q&A round. So please stay tuned for this question and answers. Thank you so much. Topesh da, you can start off.
Okay. So good evening. I am sharing my screen. Is it visible?
Yes, sir. Visible. Perfectly.
Okay. So my topic was actually non-surgical management of esophagogastric tumors. So today I am going to discuss about the management of cervical esophageal cancer, lower esophagus and G-junction tumor, rest of the esophageal cancer, because I have divided esophageal cancer like this: cervical, lower esophagus and G-junction. These are the separate entities. Another is the rest of esophageal cancers, role of neoadjuvant and definitive treatment, management of advanced disease, and a bit of radiation planning. So my focus of today's presentation will be management of esophagus and G-junction tumors. Stomach altogether a different topic. So it will be beyond the scope of my presentation within 40 minutes time. So I sincerely apologize for that. Already Dr. Biprodas has mentioned about the anatomy of esophagus, where all these landmarks are very important. So cervical esophagus comes from 15 to 20 from the incisor tip. Upper thoracic is from 20 to 25. Actually, landmark is the esophagus vein anatomically. And middle thoracic from esophagus vein to inferior pulmonary artery, that is around 30 centimeter. And 30 to 40 is the lower esophageal tumors. And if we divide the G-junction tumors, we all know the Siewert classification. Siewert 1 actually is a 1 to 5 centimeter when the epicenter of the tumor is located within 1 to 5 centimeter of the G-junction, and Siewert 2 will be, say, 1 centimeter above the G-junction and 2 centimeter below it, and type 3 will be below that. So type 3 actually behaves more like a gastric cancer. So if we see the cervical esophageal cancer management, because cervical esophageal cancer is a separate entity, and Dr. Biprodas has already mentioned that there is very little role about surgery, and we should treat it as an esophageal cancer according to the present HSCC 8 staging classification. But look at what is the problem with cervical esophageal cancer management. Most cervical esophageal cancers are not amenable to surgery. Why? This would involve functionally devastating resections of portions of the pharynx, larynx, and cervical esophagus. So you may land up in pharyngo-laryngo-esophagectomy, which is totally devastating. It should be treated like head and neck cancer, as what I want to mention, like as a clinical oncologist, the way we treat head and neck cancer, locally advanced, like with chemo radiation or radiation alone, where it is not possible. So we should treat cervical esophageal cancer with a non-surgical approach, and that if it is possible with chemo radiation. So laryngeal and pharyngeal preservation is possible. Morbid surgeries can be avoided. Outcome of surgery and chemo radiation are similar. I will show in my next slide. And radiation dose commonly used are 60 to 66 gray at the rate of 2 gray per fraction. These points are all important for us, because this is the way we have to manage cervical esophageal cancer. So let's see the data. This is the surgical outcomes. Surgical outcomes in carcinoma esophagus. So patients treated with definitive surgery had morbidity rates of around 60 to 70%. What is the mortality rate? If we see in all these studies, like Tribulate, Wong, Daiko, Tong, all these studies have shown mortality rate around 7 to 11%, and overall survival rate comes in the tune of 25 to 30% in the 5-year overall survival. If we see the morbidity is really high, which I have already mentioned. What is the outcome of chemoradiation in carcinoma esophagus? If we see these studies, these are Cow et al. In 2015 and 16, Grass in 2015. So all these are important studies because in cervical carcinoma of esophagus, in cervical esophageal carcinoma, the number of studies are very less. But these are few studies where the sample size is reasonably good, like 71, 115 or so. So they have used around 54 to 70 gray dose. And if we see the local regional control, it comes around 2 year around 70%. And if we see the survival, 2-year survival comes in the tune of 35 to 40%, and 5-year survival around 28%. So it's equivalent to surgery. Morbidity is less, mortality is less, as well as laryngeal, pharyngeal preservation is possible. So if we see the management algorithm of cervical esophageal cancer, so if it is a squamous, mostly it will be squamous cell carcinoma, histologically proven. We will go for clinical staging with like PET CT, endoscopic biopsy already done, baseline blood investigations like complete blood count, serum, LFT, KFT, electrolytes. And if the patient is fit for concurrent chemoradiation, yes, you will go for concurrent chemoradiation. Dose will be like 60 to 66 gray in 30 to 33 fractions at the rate of 2 gray per fraction. And what will be the concurrent chemo? Most of the studies have used like head and neck, concurrent chemo, cisplatin 100 mg per meter square 3 weekly or 40 mg per meter square weekly. We also follow the same kind of protocol in cervical esophageal cancer. And if it is external beam radiation alone, where maybe due to deranged RFT or poor performance status, you may not be able to deliver concurrent chemoradiation, there it is external beam radiation alone, 60 to 66 gray at the rate of 2 gray per fraction. So if we see the rest of the esophageal part, so surgery is the cornerstone of treatment. Although only 30 to 40% of patients have potentially resectable disease at presentation, and surgery has been the cornerstone of treatment. 5-year survival after surgery comes around 15 to 20% in different series. So then we were not satisfied with surgery alone. We need something more. So people tried for pre-operative treatment before surgery. So how it helps? It controls micrometastasis. Intact blood supply to tumor may improve the delivery and effectiveness of chemotherapy and radiation. It downstages the tumor and facilitates curative R0 resection. It may also help to identify tumors with aggressive biological behavior and therefore guide further treatment. So these were the rationale or logic behind pre-operative treatment. So what we found? First, let us discuss what happened with pre-operative chemotherapy. So which Dr. Viprodas has already mentioned that this was the landmark trial MRC OEO2. What they have done, they have used 2 cycles of cisplatin 80 mg per meter square by intravenous infusion over 4 hours on day 1 and fluorouracil 1000 mg per meter square, and they have given 3 weekly regime, and fluorouracil was infused over 96 hours period, that means 4 days. What they have found actually, so this was a 400 patients in the NACT followed by surgery arm, and around same 400 patients in the surgery arm. So histology, if we look at, 2/3 of the patients in both the arms were adenocarcinoma and 1/3 had squamous cell carcinoma. If we see the location, 65% of the patients had lower third esophageal tumors and only 1/4 had middle third location. So what was the benefit of chemotherapy, neoadjuvant chemotherapy over surgery? If we see the benefit, it was around 5-year 23% versus 5 years 17%. So there was absolute benefit of 6%, and that was statistically significant. P-value was 0.03. So from this trial, we got that neoadjuvant chemotherapy has a definite role before surgery in case of carcinoma esophagus. And what about the histology? If we look at the histology, both in adenocarcinoma and squamous cell carcinoma, both it has shown benefit. So it was almost like a same absolute benefit, like 22.6 versus 17 or 25.5 versus 70. So almost around 5 to 6% benefit in both the histologies we got. R0 resection rate in the chemotherapy followed by surgery arm was around 42.4%. So this trial showed that neoadjuvant chemotherapy has benefit with surgery. So what happened to this trial? This was the Rtog 8911 trial. This was also another landmark trial. What it has shown? So if we see the NACT before surgery, there was 213 patients in the chemotherapy followed by surgery arm, and in surgery it was 227 patients. If we see the histology was a bit different here. It was squamous cell carcinoma in 98 patients. A significant number of patients had squamous cell carcinoma in this study, both in the neoadjuvant chemo followed by surgery and surgery alone. And adenocarcinoma also 115 and 121 patients. What was the median overall survival? If we see chemotherapy followed by surgery and surgery, there was actually no difference. It was 14.9 months versus 16.1 months, and 2-year OS was almost 35% versus 37%. If we see the R0 resection, almost it was also similar. So two trials have shown totally contradictory results. MRC OEO2, there is benefit. Rtog 8911, there was actually no benefit. So why these contradictory results in MRC OEO2 and Rtog 8911? This was quite important. So whether we will use chemotherapy or not, that came into a big question. So inadequate amounts of cisplatin and fluorouracil were given in Rtog 8911 trial. One. Second, only 2/3 of the patients received all the 3 planned cycles of preoperative chemotherapy in Rtog 8911. And only a very small subgroup of patients received any postoperative treatment. They were not fit for any postoperative treatment at all. So chemotherapy was inadequate in Rtog 8911. And another important point is, if we see the 12-week duration of chemotherapy regime in Rtog 8911 compared to only 6 weeks in OEO2. So a failure to respond to preoperative chemotherapy in OEO2 study meant a 6-week delay in potentially curative treatment. Actually, you have delayed the surgery without any benefit, and that led to detriment. A failure to respond in intergroup study means a 12-week delay, which may have allowed disease progression. So these are the possible hypotheses why we have not got any benefit in Rtog 8911 as compared to OEO2. So preoperative chemotherapy, there was definitely controversial results. Then people thought, okay, so chemotherapy has given us controversial results. Same kind of work was going on with preoperative radiation also. So people have tried for preoperative radiation alone. So this was a Cochrane collaboration review where they have found that based on existing trials, there was no clear evidence that preoperative radiotherapy improves the survival of patients with potentially resectable esophageal cancer. These results indicate that if such preoperative radiotherapy regimens do improve survival, then the effect is likely to be modest. So there was only 3% benefit, and that too was statistically not significant. So still now, what we have got, how the neoadjuvant approach has been evolved. Preoperative chemotherapy, MRC OEO2, Rtog 8911, contradictory results. So we are in dilemma. Preoperative radiotherapy, it has not shown any benefit according to the Cochrane review. So what to do? So preoperative radiation no benefit. Now came the big question, whether we will go for people then tried, how to add chemotherapy along with radiation, and what is the effect of, instead of neoadjuvant chemotherapy and neoadjuvant radiation, how actually neoadjuvant chemoradiation helps over that. So there are actually 4 important meta-analyses on neoadjuvant chemoradiation versus neoadjuvant chemotherapy. So what happened? This was the study published by Gebski et al. It was published in 2007. What they are saying, the hazard ratio for all-cause mortality with neoadjuvant chemoradiotherapy versus surgery alone was 0.81, corresponding to a 13% absolute difference in survival at 2 years, with similar results for different histological tumor types. And for squamous cell carcinoma, it was like 0.75 and 0.75 for adenocarcinoma, actually 0.84 for squamous and 0.75 for adeno. So the hazard ratio for neoadjuvant chemotherapy was 0.90, and which indicates a 2-year absolute survival benefit of 7%. So what they have shown, that chemoradiation, irrespective of histology, they have given around 13% benefit in 2 years, and chemotherapy was giving 7% benefit. So what they have interpreted? They have interpreted a significant survival benefit was evident for preoperative chemoradiotherapy, and to a lesser extent, because it was 13 and 7, for chemotherapy in patients with adenocarcinoma of the esophagus. The findings provide an evidence-based framework for the use of neoadjuvant treatment in management decisions. So what they are saying, okay, both have given benefit. Neoadjuvant chemoradiation has given slightly better benefit, that was 13%, and neoadjuvant chemo 7%. Then came the important meta-analysis, that is by Zoquist. This was updated meta-analysis published in 2011. This was from the Australian group. What they are saying, they contain 4188 patients, where the previous publications it was only 2933, and they interpreted that the hazard ratio for all-cause mortality for neoadjuvant chemoradiotherapy was 0.78 for squamous cell carcinoma. So the hazard ratio for squamous cell carcinoma was 0.80, and for adeno it was 0.75, and overall it was 0.78. And the hazard ratio for all-cause mortality for neoadjuvant chemotherapy was 0.87 and 0.8. So what they have interpreted, this updated meta-analysis provides strong evidence for the survival benefit of neoadjuvant chemoradiotherapy or chemotherapy over surgery alone in patients with esophageal carcinoma. So what they are saying, that both neoadjuvant chemoradiation and neoadjuvant chemo has shown benefit, but they can't compare one over the other, or they can't say which one was better than other. So these results should help inform decisions about patient management and design of future trials. So, but they could not conclude efficiently. Then came this important network meta-analysis, and this meta-analysis has shown that neoadjuvant chemoradiotherapy improved overall survival when compared to all other treatments, including surgery alone, neoadjuvant chemotherapy, and neoadjuvant radiotherapy. However, the risk of post-operative mortality increased when combining neoadjuvant chemoradiotherapy to either surgery alone or to neoadjuvant chemo. So to conclude, they say that neoadjuvant chemoradiotherapy improves overall survival than all other modalities, but may also increase the risk of post-operative mortality in patients of locally advanced resectable esophageal cancer. What the fourth meta-analysis say? They are saying, this was the new EC study, this was the Chinese meta-analysis published recently. They provided high-quality evidence supporting the survival benefits of neoadjuvant chemoradiotherapy or neoadjuvant chemotherapy over surgery alone, with neoadjuvant chemoradiotherapy presenting the greatest benefit for esophageal carcinoma. So before there was a confusion about the chemotherapy, there were contradictory results. Pre-operative radiation, no role. Neoadjuvant chemoradiation over neoadjuvant chemotherapy, there are many opinions. So what to summarize till now? NSCTRT and NSCT both have better outcome as compared to surgery alone, no doubt. Second, neoadjuvant chemoradiotherapy has shown better outcome in both adeno and squamous cell carcinoma. Clear. Third, superiority of neoadjuvant chemoradiation over neoadjuvant chemotherapy proven indirectly or directly in squamous cell carcinomas. So from all these meta-analyses we have got, yes, there is some benefit of neoadjuvant chemoradiation over neoadjuvant chemotherapy in squamous cell carcinomas. Updated meta-analysis further confirmed no significant difference among neoadjuvant chemoradiation, neoadjuvant chemotherapy, and surgery alone in terms of 30-day post-operative or in-hospital mortality. So these are the crux of all these meta-analyses which we could get. So anyhow, from all these trials, what is clear that we need some neoadjuvant treatment. Neoadjuvant chemoradiation has shown benefit in all histologies. Neoadjuvant chemoradiation has shown superiority in squamous cell carcinomas marginally over NSCT, and there is no like significant post-operative mortality or morbidity after neoadjuvant treatment. So this trial was also mentioned by Dr. Viprodas. This was the landmark trial which came from Netherlands in 2012, and it changed the picture. So here there was 363 patients, and the patients were either T1, N1, M0 or T2, T3, N0, N1. And both adenocarcinomas and squamous cell carcinomas were there. So what they have given? They have randomized into two arms. Neoadjuvant arm contains radiation of 41.4 gray in 23 fractions at the rate of 1.8 gray per fractions. Chemotherapy concurrent was carboplatin AUC2 and paclitaxel 50 mg per meter square weekly, followed by resection after 6 to 8 weeks. And second arm was resection. What was the primary endpoint? Primary endpoint was overall survival. So what they have got, if we look at the detail of this cross trial, this is quite important. So in this trial, 75% were adenocarcinomas, squamous cell carcinoma only 1/4. If we see the T stage, mostly it was T3 disease, and there was no N2 disease, all were N0 or N1. What was the overall survival benefit? Already we have seen it was 49 months median versus median 24 months in the surgery alone, and that was statistically significant. If we see according to the histology, adenocarcinoma, there was 43.2 versus 27, and in squamous, there was a huge gap. It was 81.6 versus 21 months. But in all histologies, it was significant. R0 resection in the NSCTRT arm, it was 92% versus 69%. And if we see the PCR rate, pathological complete response, it was 29% overall, and 49% in the squamous, and 23% in the adeno. So this trial changed the entire scenario. And if we see the cross trial, here this was already shown, and here you can see the gap in the squamous between chemoradiation and surgery, and here also there is a definite improvement in adenocarcinoma as well. Here you can see the gap in the Kaplan-Meier. So cross protocol widely practiced all over the world as the neoadjuvant strategy for resectable esophageal cancer, and we have done our analysis in our institute also, because just cross came in 2012. After that, we also started following the cross protocol in our institution. And if we see, this is the result. And in squamous cell carcinoma, in the cross, it was only 23%, but our 95% was squamous cell carcinoma in our case. If we see the grade 3 toxicity, it was 7% versus 10.7 in our institute. 2-year survival, it was 67% in the cross. And this was all squamous results. And here it was around 7. This was a hit. Here it was 75.9%. Median overall survival, if we see in the cross, it was 81.6 months. In our study, it came like 86 months, but sample size was small, 84 patients, and follow-up was also not that good like cross. R0 resection, if we see, we have also done quite good. And PCR rate, in our case, it was 40.5% as compared to 49% in the real cross squamous cell carcinomas. This was less because in our patients, mostly there are many patients who had T4 disease, N2 disease. So we could not get that much 49% of PCR rate. So we have discussed about the pre-op chemotherapy in esophageal cancers, role of pre-op chemoradiation, role of radiation, and now we will talk about non-surgical definitive management of carcinoma esophagus. Where we follow that? Yes, Dr. Biprodas will say, no, this case is unsuitable for surgery, maybe due to the extent of the disease, location of the disease, patient is not fit for surgery due to comorbidities, performance status, or the patient is denying surgery, then definitive non-surgical management is the option. What is the option? You have radiotherapy alone, you have concurrent chemoradiation. So let's look at that. So if we see this landmark trial, it was Rtog 8501, published in JAMA. They have compared CTRT versus RT alone. So what they have done in the CTRT arm, it was 50 grade 25 fractions along with cis5FU, 2 cycles concurrent and then adjuvant, and RT alone, it was 64 in 32. If we see the 5-year and 3-year survival, comparing CTRT versus RT, it was horrible results in the RT alone. 5-year and 3-year survival was 0%, and in CTRT, it was 30 and 27. Persistent local disease was also lower in the CTRT arm as compared to RT alone. And if we see the distant metastasis as the first site of failure, it was quite low in CTRT arm as compared to RT alone. Grade 3 toxicity, slightly higher in the CTRT as compared to radiation. So from this, we could get that yes, CTRT was better than RT alone, no doubt, in terms of overall survival, in terms of control of the disease, everywhere it shows dominance. Now question is that what about if we intensify the further radiation dose in chemoradiation from 50 to say 60 or 64 in the tune of radiation alone? So this was another landmark trial, intergroup 0123, where they have intensified radiation dose. So chemo plus radiation 64.8 versus chemo plus 50.4 grade. So this arm was like the concurrent chemoradiation arm as in JAMA, as in Rtog 8501, and this was the escalated radiotherapy arm. So what happened? 2-year survival was 31% versus 40% in the lower dose of radiation. Median overall survival was also less with intensified radiation. Here we can see 13 months versus 18 months, and loco-regional persistent of disease or failure, it was almost similar, 56 and 52. So when we have intensified the radiation dose in that era, that should be mentioned, there was no benefit in intensifying radiation dose in concurrent chemoradiation therapy, because the radiation which was used at that point of time, there were many patients who were treated with 2T radiation. If we see the field size that was used, like 5 centimeter craniocaudally, we have treated a lot of patients like that. So this might have led to this detriment in the intensified radiation arm. Due to higher toxicity, it has led to overall survival decrement. So what we have got till now, CTRT with 50 gray at the rate of 2 gray per fraction equivalent is the standard till now. Radiotherapy dose escalation still not beneficial in concurrent setting. Dose escalation studies with IMRT and conformal techniques are going on, but still we are following CTRT with 50 gray at the rate of 2 gray per fraction. Yes, there are many dose escalated studies are going on, starting from scope 2, and many other trials are there. So now we have seen the results of CTRT, so radiation along with chemotherapy. So what is the result of CTRT with targeted agents? We all know that overexpression of EGFR was detected in 30 to 90% of esophagogastric tumors, which correlates with increased invasion, dedifferentiation, and worse prognosis. So this was trial from UK, that is scope 1 trial, which was done in UK. What they have done, there were two arms. So arm A had cisplatin and capecitabine 2 cycles, followed by cisplatin capecitabine along with radiation. And arm B has cisplatin capecitabine and cetuximab, followed by cisplatin capecitabine plus cetuximab with conformal radiation. So 2 cycles of neoadjuvant followed by concurrent chemo radiation, one with only chemo and another with chemo plus targeted agents. So what they have found, if we see the updated results of SCOPE, yes, Ctrt plus cetuximab has not done well, and actually it has shown detrimental results. It was median overall survival in the Ctrt, it was 34.5, and in the cetuximab it was only 24.7. 3-year overall survival was also low in the cetuximab arm. So what we can say, that control arm of SCOPE 1, that is the chemoradiation, is a reasonable alternative to surgery, particularly in patients with borderline fitness, where surgery is considered a high-risk procedure. And actually, in our institute also, we are following the SCOPE protocol, because we know that even in the CTRT, 15 to 20% patients will have distant relapse. So it will take care of the micrometastatic disease. We can buy time for radiation also and for better radiation planning. So we are following this protocol in our institute in the concurrent chemoradiation setting. Other than cervical esophageal carcinoma, rest of the esophageal cancer, like mid-thoracic or so, we are following this SCOPE 1 protocol. So if we see the SCOPE 1 results, there were stage 3 where 60% patient had stage 3 and there was no 4A patients. But in TMC, we have treated like that 36 patients, initial results, and we see that 44.4% of our patients had stage 4A disease. And if we see the location, it was like most of the patients had mid or lower esophageal lesions. Most of them had squamous cell carcinomas, and median overall survival in SCOPE 1 initial results was 26 months. We had around 28 months. 2-year overall survival was also similar. So if we follow the protocol properly, then we can also achieve a good outcome. So our results also reflected that. So here also see that local progression-free survival around 21.6 months. 2-year, it is around 71.2% in our patients also. So now I told that there is a separate entity called G-Junction, lower esophagus and G-Junction tumors. So till now we have got the idea about the esophageal cancer. Now what about the G-Junction tumors? And what is the role of non-surgical parts? So this was the landmark trial, MAGIC trial. What they have done ECF followed by ECF3, followed by surgery, followed by again ECF3. And lower esophagus and esophagogastric tumors were 25% of the patients, rest were gastric carcinomas. So what they have shown, there was definitely benefit in both overall survival and progression-free survival. So surgery plus preoperative chemotherapy, 2-year survival 50% versus surgery alone 41%. So there was a 9% 2-year benefit. 5-year benefit was almost 13%. And there was a median overall survival benefit of 4 months. Yes. So in lower esophageal adenocarcinoma, or if it is a G-junction adenocarcinoma, yes, MAGIC has definitely shown magic. And PCR rate was 8% and leads to downsizing of the tumor, significantly PFS and OS benefit. But we were not satisfied with that. So this FLOT4 came.
Sorry to interrupt, sir.
Yeah.
Sir, sorry to interrupt. You have another 4 minutes.
Okay. Okay. So I will take few more minutes and I will finish it off. Sure. Thank you. So FLOT4. So there was a comparison between FLOT4 and actually the MAGIC ECF versus FLOT4. And here also FLOT4 had shown overall survival benefit and median it was 50 months versus 35 months. So FLOT4 currently is the standard of care if patient is fit for that, say lower esophageal adenocarcinoma or G-junction adenocarcinomas. Here we can see the morbidity, or here we can see the toxicity pattern. So in resectable lower esophageal and G-junction adenocarcinoma, FLOT4 is currently the standard of care. So now question came, whether FLOT is better or whether CROSS is better, whether MAGIC is better. So ESOPEC trial is going on between the FLOT versus CROSS, and NeoAegis is comparing MAGIC versus CROSS. So these results are pending. We are waiting for that. So still now, if we summarize the management of carcinoma esophagus for the curative intent treatment, So early localized T1N0M0, if we divide it in T1A N0M0, it is only possible to detect with endoscopic ultrasound. Then you go for endoscopic mucosal resection. If margin positive or deeper invasion, like submucosa involvement or more, then you go for a radical surgery like TT or TH. And if it is a T1B disease onwards, then you definitely go for a radical surgery, transthoracic or transhiatal esophagectomy according to the location. No adjuvant treatment. Management of carcinoma esophagus, it is a locally advanced disease. Cervical esophagus, it is concurrent chemo radiation. If not possible, then you go for radiotherapy alone. If it is upper and middle thoracic esophageal carcinoma, both squamous and adeno, resectable, then neoadjuvant chemoradiation with cross protocol followed by surgery. If it is unresectable, then you go for a definitive chemoradiation according to your institutional protocol. If it is a lower thoracic esophageal cancer, squamous, again you come to the loop of cross, like NSCTRT, cross protocol surgery. If it is adeno, follow FLOT4, surgery FLOT4, or magic ECF, surgery ECF. You can follow according to the performance status, according to the fitness of the patient. What about the advanced disease? What is the role of targeted agents? So there comes, we know that there are significant proportion of patients, around 30% of the patients has HER2 positive disease, especially these adenocarcinomas. Then this was the landmark TOGA trial, which has shown benefit, around 3 months overall survival benefit when we added trastuzumab along with Ciscap, and it was OS was 13.8 versus 11.1 months. Then what is the role of immunotherapy in advanced esophageal cancer? So this was the keynote 181 study. So which patients are fit for that? Pembrolizumab after first line of prior chemotherapy, pembrolizumab 200 mg every 3 weekly up to 2 years, and combined CPS score was more than 10. They have actually shown much benefit if it is a squamous cell carcinomas and CPS more than 10. 1 year overall survival was 43% versus 20%, and that was statistically significant. So now come to the palliation. For palliation, you have many options, which already Dr. Viprodas has mentioned: stents, feeding tubes, different chemotherapy regimes like epirubicin, cisplatin, ciscap, oxaliplatin based, and always you have the external radiation or intraluminal brachy or a combination of these approaches. Palliative radiation, it will be like if it is a M1, M0 with poor KPS, dose fractionation 30 to 39 in 10 to 13 fraction. Concurrent chemo, no. Radiation beams, APPA, and image guidance, EPID on day 1. So now just a brief about radiation planning. So we have all got the idea about stage-wise management of carcinoma esophagus and G-junction tumors. So you all know the setup and immobilization is very important, and patients are placed in a reproducible position with arms up, T-bar or equivalent immobilization. We follow this. Uniform 2.5 mm slice thickness. Diagnostic PET CT can be used for radiotherapy planning, but we are not using it. We are using for the planning purpose. So what about the cervical esophageal cancer? How you are going to contour? So GTV, or grossly positive disease of the primary tumor as seen on exam, on laryngoscopy, diagnostic and planning CT scan. So GTV node, involved node, and CTV, GTV plus 3 cm craniocaudal margin or 1 cm above any grossly involved periesophageal nodes, whichever is cephaloid. And you can give 1 cm of radial margin, but you have to respect the boundaries like vertebral body, trachea, pleura, vessels, and all. Nodal area, elective nodal area to be treated, 3, 4, 5, and 6. PTV, you follow the institutional protocol. This is the contouring guideline of the cervical esophageal cancer. Here you can see all the diagrams, and never go beyond the cricoid cartilage. Your cranial border should come, cranial border limit will be around the cricoid cartilage. What about the target volume delineation of other subset of patients? You see the GTV grossly found on endoscopy, PET CT, GTV node grossly involved regional nodes, CTV craniocaudally go 3 cm supero-inferiorly to cover the submucosal lymphatic spread, and 1 cm above any grossly involved periesophageal nodes. And here also you have to respect anatomical boundaries, PTV according to the institutional protocol. So here, this is our patient where we have contoured like this. Here you can see this is the gross disease. This is the CTV where we have respected lung, blood vessels, heart, all we have respected. Here, this is, you can see the sagittal section. And here you can see this is a grossly involved node. We have covered the primary as well as the nodal area. So this is the contouring atlas of rest of the esophageal tumors, where we have given craniocaudal margin of 3 cm around the GDV, 1 cm radial margin. We have given respect to the anatomical boundaries. And if it is a lower esophageal cancer, coming to G-junction, cover the abdominal nodes like celiac plexus. Here also we have taken that, and here you can get a L-shaped field, which also you find in 2D planning also. And when you plan with 3D CRT, you can plan with 3 field placement, like 1 anteroposterior, 2 posterior oblique. According to the need, you can plan with the 4 field planning to reduce the OAR doses. And what is the role of IMRT in esophageal cancer as compared to 3D CRT? Yes, IMRT has been shown to significantly reduce dose to the lung and heart, lower risk of grade 3 or higher non-hematological toxicities. And although IMRT has not yet emerged as a standard of care for esophageal cancer generally, it is clearly preferable for cervical esophagus because of close proximity to the critical structures. So these are the dose constraint. As a student, you should remember spinal cord 40, V20, 30, V10, 50. That means volume of the lung receiving 20 gray, 10 gray, and 5 gray. It will be 30, 50, and 70%. Mean lung dose was less than 15. Heart mean, we try to keep it less than 26. And these are the dose constraints you need to remember. So this is all about the management of carcinoma esophagus and G-junction tumor as far as clinical oncology is concerned. I sincerely apologize because I could not go to the stomach part. Here I have to finish it all. Thank you very much.
Thank you, sir. Thank you for that excellent lecture. I think we'll discuss with the questions later after the third lecture. So I'll invite Dr. Indranil Mollik for his lecture, his class. Dr. Indranil Mollik, please, consultant radiation oncologist of TMC Kolkata.
Good evening, everyone.
Good evening, sir.
Just let me share. One second. So I hope everybody can see my screen.
Yes, sir. It's visible.
So thank you to the West Bengal AROI organizing committee for this lecture series. It's a very comprehensive series, and I must congratulate the team for doing all this hard work. So the topic that has been given to me is to discuss rectal cancer. Now, rectal cancer is a very, very big topic. And I'm going to try my best to take you over the important issues in rectal cancer over the next 40 minutes or so. At the outset, let me thank the colorectal team, a multidisciplinary team at Tata Medical Center, without whom, of course, our treatment practices would not be complete. What I'm going to discuss over the course of the next half an hour or so is an overview of evidence-based management. And at the end of that, we'll briefly discuss anatomy and target delineation. Now, total mesorectal excision forms the basis of, or is the fundamental fulcrum on which the treatment of rectal cancer rests. And traditional management includes either long course chemoradiation or short course radiotherapy before it. And possibly, till a few months back, traditionally, there would be a question of giving chemotherapy after that. Now, we are going to discuss today what is the need for radiotherapy before surgery? Why do we do total mesorectal excision?
How do we choose between long course chemoradiation and short course radiotherapy? Do we need chemotherapy at all? And finally, how should we fit in the chemotherapy into the management of rectal cancers? So to start off, what is the role of radiotherapy in rectal cancer? Now we have to go back a few decades, at least 3 decades to be exact, to look at how radiotherapy plays a role in rectal cancer. At that time, and this was in the 1980s and 90s, traditional surgery for rectal cancer was associated with a substantial risk of local failure. And by traditional surgery, I would say that this would be an anterior resection done traditionally or an abdominoperineal resection. And at that time, it was calculated from the Colorectal Cancer Collaborative Group, published in the Lancet in 2001, based on studies published till that time, that without radiotherapy, local regional failures were in the range of 25 to 28%. And what radiotherapy did was that it brought down the rate of local failures to 15, 16%. So let's say it brought it down to half its original value. However, due to a high incidence of systemic failures, its effect on survival was not so obvious. So although there was an improvement in survival, that was just missed being statistically significant. Now, the first piece of evidence that we have to understand is that the first randomized control trials, and rectal cancer is very fortunate in that respect that there have been very many large randomized control trials to help us make very clear decisions on rectal cancer. So the first piece of evidence are the large randomized control trials done in the Scandinavian countries, which looked at a short course of radiotherapy before surgery in operable rectal cancers. And there were 3 large Scandinavian trials. The Stockholm 1 and the Stockholm 2 trials were done in the 1980s. And what they did was that in operable rectal cancers, and remember there was no imaging at that time, so these were all clinically examined operable rectal cancers, they were randomized to either surgery alone in the traditional way or preoperative radiotherapy. This was given in 25 gray in 5 fractions, that's 5 gray per fraction over a week. And surgery would be done within a week of completion of this radiotherapy. The Stockholm 1 trial found a significant reduction in local recurrence, but no difference in overall survival. But the post-op mortality was also higher because they basically used an APPA portals, large APPA portals to deliver this, and there was more post-operative complications. With better field arrangements, the Stockholm 2 study not only showed a significant reduction in local recurrence, there was a significant reduction even in distant metastases and an improved overall survival. And the post-op mortality was now much lower with better designed, slightly conformal fields with blocks, etc. Parallel to this, the Swedish rectal cancer study, which was a bigger study of 1,168 patients, also had the same design. This was in the later part of the 1980s and was published, over a 13-year update was published in 2005. Again, it showed significantly better local control, better cause-specific survival, and overall survival. They did a subset analysis which showed that tumors which were more than 10 centimeters above the anal verge did not show a survival benefit. And stage 1 tumors also had a significant benefit. So this benefit was not limited to more advanced tumors. There was a benefit even in stage 1 cancers. So this set the background for the use of neoadjuvant short course radiotherapy in rectal cancer. But at the same time, there was a paradigm change in surgery for rectal cancers. In the UK, a surgeon called Heald in 1982 first published a data set where he proposed that instead of doing traditional surgery, which would basically take out the rectum with a margin around it, he proposed that we need to take out the mesorectum in toto, which means that take out, as this diagram suggests, all the tissue, the fat and the lymph nodes from the rectal wall back up to the sacrum, all around the entire tissue within the mesorectal fascia. Because there was this fear, or there was this hypothesis that rectal cancer would spread via lymphatics to lymph nodes a few centimeters below the primary tumor to a few centimeters above the primary tumor. And if you didn't take out the entire mesorectum, that was what was causing the high incidence of local failure. And this was replicated up to the 2000s by several people who now showed that the local recurrence rate could be brought down to less than 10%. Just imagine, from 25 to 28%, local recurrence rates dropped to less than 10% with an improvement in surgery. And the total mesorectal excision is the most important thing that you can do in rectal cancer. It is by far the greatest discovery in rectal cancer treatment. So the question now arose that if surgery itself is bringing down the local failure rate to 10% or less, what is the need to give radiotherapy at all then? Because radiotherapy was basically helping when the local control rate was high. So what is the role of radiotherapy with modern surgery? So to answer this question, again, it was in Europe, in the Netherlands, that a very large randomized control trial took place. This trial is known as the Dutch TME trial. Here, nearly 2,000 patients were randomized to standardized TME alone versus preoperative radiotherapy with short course radiotherapy, followed by standardized TME. The radiotherapy portals included the tumor bed and pelvic nodes only, with a 3 or 4 field plan. Amazingly, it was seen that despite the low incidence of local failure with standardized TME, radiotherapy could further reduce local failures. So from 8.2% with surgery alone, it became 2.4% with a 2-year follow-up, and at the 11-year follow-up, it was 11% versus 5%. The overall survival was not different, but the cause-specific survival was better with radiotherapy when R0 resection was performed, and OS was better with radiotherapy in a subset of patients with stage 3 tumors with R0 resection. So this graph, or this table, shows what I just mentioned, that the 10-year local recurrence in tumors was significantly reduced. And in patients with a negative CRM in TNM stage 3 tumors, the overall survival was also reduced. But a group of people were asking, can we select high-risk patients? Instead of giving neoadjuvant radiotherapy to everyone, could we select high-risk patients? Could we do the TME first, then see who are the people at high risk by way of positive margins, and then only give radiotherapy to them postoperatively, and maybe that would be good enough. In the UK, the MRC ran this important study known as the Cr07 study. The Cr07 study was also a very large study of 1,350 patients, which randomized patients to upfront TME, and if the CRM was less than 1 millimeter, to be followed by chemoradiation to 45 gray in 25 fractions, versus preoperative radiotherapy followed by TME. All patients underwent adjuvant 5-FU-based chemotherapy. Interestingly, this study also showed that neoadjuvant radiation significantly reduced local failures from 10.6% to 4.4%. The disease-free survival was also significantly better. However, there was no benefit in overall survival. So this made it very clear that radiotherapy should be given to everyone before the surgery and not on a case-by-case basis after the surgery. Now, this was the situation in Europe. So as you can see, we've got the Scandinavian studies, we've got the Dutch study and the UK study, but across the Atlantic, in the United States and in some countries in Europe, like Germany, the tradition was to give post-operative radiotherapy rather than pre-operative radiotherapy. So naturally, a question arose that which is a better way to do things. Here we come to the German rectal cancer study, which is another seminal paper in rectal cancer. Now, in the German rectal cancer study, locally advanced or node-positive rectal cancers were randomized to post-operative radiotherapy, so TME followed by chemoradiation, to a dose of 55.8 gray over 31 fractions with 5-FU-based chemotherapy by continuous infusion, versus neoadjuvant chemoradiation with 5-FU-based chemotherapy followed by surgery with TME. And all of these were followed by 4 cycles of 5-FU-based adjuvant chemotherapy. It was shown that the neoadjuvant chemotherapy or the preoperative radiotherapy was better. The local control was significantly better with preoperative radiotherapy. The failure rates were 8% versus 13%. There was no difference in overall survival. But importantly, the preoperative radiotherapy had significantly less acute toxicity and late toxicity compared to post-operative radiotherapy. And this is important to understand because in a post-operative setting, there is more small bowel in the pelvis, which causes more acute toxicity and more consequential late toxicity from the extra acute toxicity. What this trial also showed was that in a subset of patients who were upfront thought to be candidates for abdominoperineal resection, sphincter preservation could be done in low-lying tumors where an APR would otherwise have been done. And the sphincter preservation rate was quite interesting. It was significantly higher in the neoadjuvant or the preoperative chemoradiation group. Now, this is, of course, a matter of institutional protocol. A number of surgeons feel that if preoperatively the tumor is going down low enough to do an APR, many people would not change their surgical practice based on the shrinkage after chemoradiation. But more and more people are trying sphincter preservation approaches from low anterior resection to ultra low anterior resection in order to give patients a chance to have a normal sphincter. Now, it is an important question to ask that when we say that neoadjuvant chemoradiation or short course radiotherapy is important for all rectal cancers, is there no subset of rectal cancers that does not benefit from this chemoradiation or short course radiotherapy approach? And to investigate whether there is a subset of low risk cancer patients, we need to go to MRI based staging. So a group from the Royal Marsden Hospital, radiologists Gina Brown and Taylor, standardized the MRI-based preoperative staging of rectal cancer. And they divided T3 rectal cancer into 4 parts based on the extent by which the tumor was going outside the muscularis propria. And this is, as you can see on the screen, there's T3A, B, C, and D, and there are these distances of less than 1 millimeter, 1 to 5 millimeter, 5 to 15 millimeter, and more than 15 millimeter. And they designed in the Marsden a study known as the Mercury study. Now, this was not a randomized control trial. So it was a prospective longitudinal study where they took nearly 400 patients of operable rectal cancer. They all had standardized high-resolution MRI. The poor prognosis ones underwent preoperative radiation, chemoradiation, followed by surgery. The good prognosis ones did not have preoperative treatment. And good prognosis included CRM not involved, tumor spread less than equal to 5 beyond the muscularis proprius of P3A and B, no extramural venous invasion, a clear intersphincteric plane. So about a third of tumors had good prognosis on MRI and did not receive radiotherapy. And in these tumors, there was only a 3% local failure rate. Therefore, they showed that in a prospective study, you could, if you have very good quality standardized MRI-based staging, you could reduce the need for preoperative radiotherapy in a subset of patients. Conversely, it was seen that for tumors that are slightly far away from the anal verge, so if you remember, I mentioned that the Swedish rectal cancer study found that there was less benefit or no benefit in local control for tumors which were more than 10 centimeters away from the anal verge. The Dutch TME study also showed that the benefit in local control is reduced for those increasing, with increasing distance from the anal verge. But this was not consistent. So there was a discrepancy between the different studies which looked at the distance from the anal verge and the benefit. Now, we have now two approaches to neoadjuvant chemoradiation, neoadjuvant radiotherapy. One is to give neoadjuvant chemoradiation, like the German rectal cancer study, or to give neoadjuvant short course radiotherapy before and perform early surgery. Now, if we want to optimize treatment, these are the two approaches. Long course chemoradiation to 45 to 50 gray to 5 up to 5.5 weeks, followed by a 6 to 10 week gap, and then TME, or short course radiotherapy, 5 fractions, then a less than or equal to 1 week gap, and then TME. Which protocol should we choose? Now, as I mentioned that there was geographical differences in practice between short course radiotherapy and long course chemoradiation. So 2 randomized control trials were performed, the Polish trial and the Rtog trial, which compared neoadjuvant short course radiotherapy with long course chemoradiation. They had very similar designs, and both of these studies allowed adjuvant chemotherapy at the end. The results of these studies showed that there was no difference in local recurrence rates, no difference in disease-free survival, no difference in distant metastases, no difference in overall survival. However, the Polish trial showed more acute toxicity in the long course chemoradiation arm, whereas the Rtog trial showed that in the low rectal tumors, for tumors which are in the distal part of the rectum, there was a slightly higher chance of local recurrence with short course radiotherapy. So they said that they cannot rule out higher local recurrence rate in low rectal cancer patients. To take things a bit further, the Stockholm 3 trial took 840 patients, gave short course radiotherapy followed by TME, short course radiotherapy with a larger gap followed by TME, and long course radiotherapy with a 4 to 8 week gap followed by TME. The question that they were asking was that by increasing the gap between short course radiotherapy and surgery, would we allow a greater pathological response rate and allow downstaging, which was one of the problems that was being faced with short course radiotherapy. It was not a very good treatment when you needed the tumor to shrink to allow sphincter preservation or negative CRM. They found that compared to short course early versus short course delayed, there was an improvement in YP0 or pathological complete response rate with delayed surgery. There was greater downstaging. The local failure rates were the same. There was slightly higher acute toxicity and no difference in late toxicity, and no difference in any of the other markers of local recurrence, distant metastases, disease-free survival, or overall survival. And this showed that for tumors that require downstaging, short course radiotherapy followed by a bigger gap before surgery would be a pretty good approach to follow. Now, having covered radiotherapy approaches, we come to choosing concurrent chemotherapy. Now, earlier studies have traditionally used 5-FU based, IV chemotherapy. And some of them have used infusional chemotherapy, and some of them have used continuous infusion chemotherapy over the entire course of treatment. So with the availability of capecitabine, which is a 5-FU analog, the question arose that can we replace 5-FU with capecitabine? And there are two large studies, which have compared 5-FU versus capecitabine. And both these studies show that there is no difference. And therefore, capecitabine is a very safe and convenient replacement for infusional 5-FU. The other question to ask was that if we added oxaliplatin to 5-FU capecitabine, just like you do in the adjuvant setting, for example, with the Capox or Folfox regimen, would there be a greater benefit? And there have been 3 studies and a Cochrane review, which all showed that addition of oxaliplatin does not benefit in terms of the PCR rates or in terms of survival outcomes over just giving capecitabine. So doublet chemotherapy concurrent with radiotherapy is not beneficial. What about radiotherapy dose, technique, and timing? 50 Gray, it was shown maybe slightly better than 45 Gray in terms of PCR rates and the CRM positivity rates. These are secondary interpretations from the Accord 12 study published by Gerard in JCO 2010. And there has been an NRG oncology study, the RTOG 0822, which compared IMRT versus 3D conformal radiotherapy in rectal cancer. And this study unfortunately showed that IMRT does not reduce acute grade 2 toxic GI side effects compared to 3D conformal radiotherapy. When should we do the surgery after doing the radiotherapy, especially the long course chemoradiation? There have been analyses of retrospective series which have shown that the more you wait after surgery, the greater your chance of a pathological complete response. On the other hand, studies have shown, like the Dutch colorectal cancer audit, that this benefit is only up till about 15, 16 weeks from surgery. If you wait more than that, the person decides to go home and does not come back for 4 months, then he loses the benefit of the delayed surgery. And despite waiting, there is no increase in R+ resections. A meta-analysis of outcomes of patients with a PCR. So why should we go for more PCR? Is because it has been shown that patients who achieve a PCR are more likely to live longer. Now, this, of course, is a skewed interpretation because it is more likely that the patients who achieve PCR at the same interval after surgery are likely to do better. And nobody has shown that by artificially waiting for a longer time, there is any additional benefit of achieving PCR. But it is important to know that PCR is an important prognostic factor in rectal cancer. Now, at the end of the treatment, or at least at the end of surgery, there are several quality parameters that matter. In terms of surgical parameters, it's the CRM, positivity or negativity, and the distal margins. So they need to be clear. And the distal margin, closed distal margin rate needs to be less than 10%. The CRM positivity rate needs to be less than 7-8%. Perforation rates during surgery need to be low. Length of hospital stay needs to be moderate. In terms of pathological examination after surgery, the number of nodes examined are very important. So we need to examine at least 12 to 15 nodes in the specimen. And in terms of effectiveness of treatment, we need to look at the pathological complete response rate. Now let's take a short detour to look at the question of organ preservation. How much time do I have? So organ preservation is an important question, right? So if you've got a 10-15% chance of pathological complete response, can we achieve organ preservation? Can some people avoid surgery? So in terms of reducing the cost and resource utilization, in terms of improving quality of life for patients, and in terms of avoiding a permanent colostomy, organ preservation is an important question. Now, there are two strategies for organ preservation. One is in early stage patients, where the goal is to give neoadjuvant chemoradiation and try to either do no surgery or do a transanal mucosal resection. Okay. And based on the result of that, decide on whether to do a TME surgery or not. And there has been a study which has been done in the CART study published in 2018, where they could see that this could be achieved. Mucosal resection could achieve some results in this setting. The other way this has been examined is in unselected loco-regionally advanced patients, where the goal is to give neoadjuvant chemoradiation, look at the complete clinical response rate, and then in these patients, prospectively wait and watch according to an intensive schedule. And if there is residual disease, do a planned TME. Now, can chemoradiation be enough? Published pathological complete response occurs in 8 to 27% patients, average 15%. This is associated with an excellent prognosis. And individual, as I mentioned, individual pool data meta-analysis shows that the overall survival is much better, is about a third better compared to those with residual disease. But assessing response to treatment is an intensive process. You have to do a clinical and endoscopic examination. You have to do a radiological examination with CT, endorectal ultrasound, or MRI. Baseline features are not used for exclusion, and prospective studies have been done to assess these features in order to take decisions regarding complete clinical response. And the wait and watch registry, and this is a slightly older, I think there may be an update on this registry, showed that in about 87% of patients who had a CCR went into the registry with a median follow-up time of 3.3 years. The two-year local regrowth was 25.2%, which means that in 75% patients, they did not require surgery. Most of the regrowth happened in the first 2 years. They were located in the bowel wall. The distant metastases rate was low, and the 5-year overall survival was very good with this wait and watch approach. Finally, we come to the role of adjuvant chemotherapy. Now, unlike colon cancer, where there is no neoadjuvant treatment, there was till recently no evidence specifically for rectal cancer on the benefit of adjuvant chemotherapy. In colon cancer, we have 3 large randomized control trials which show that there is a benefit of giving 5-FU-based chemotherapy or 5-FU and capecitabine-based chemotherapy after surgery. And the meta-analysis has shown that there was a 17% benefit in overall survival and a 25% benefit in disease-free survival. But more recently, there have been 4 randomized control trials, specifically in rectal cancer, which has looked at the role of adjuvant chemotherapy after neoadjuvant radiation or chemoradiation in rectal cancer. Most of these studies did not complete their planned recruitment. So individually, these are small studies, but a combined analysis of these studies showed that for single agent adjuvant chemotherapy, in a wide spectrum of patients, there was no benefit in overall survival with adjuvant chemotherapy. There was no benefit in disease-free survival with adjuvant chemotherapy. There was no benefit in distant recurrence with adjuvant chemotherapy. And however, in a subgroup analysis, there is a benefit in DFS and distant recurrences in tumors starting more than 10 centimeters from the inner verge. So what this meta-analysis showed is that the overall benefit of adjuvant chemotherapy after neoadjuvant radiation or chemoradiation in rectal cancer is suspect. It is not very well proven, but it could be beneficial in a small subset of patients with higher rectal cancers. And another meta-analysis by Bucco analyzed whether doublet chemotherapy, the earlier meta-analysis was just single agent capecitabine or 5-FU. This meta-analysis looked at trials which had used doublet chemotherapy and found that there was no benefit even with doublet chemotherapy in the adjuvant setting. Now, what are the predictors of outcomes in rectal cancer? One is the lymph node ratio, which has shown great, the number of positive nodes divided by the number of dissected nodes. The path CRM involvement and the post-RT CEA are all important criteria for predicting outcomes after the end of treatment. So therefore, who needs adjuvant chemotherapy? We may offer adjuvant chemotherapy to upper rectal tumors or path node positive or high lymph node ratio tumors. Finally, we come to the question of total neoadjuvant therapy. This is, this question has come up because the local recurrence rates are very low. But so the disease failure is mainly determined by distant metastases. So will bringing chemotherapy before the surgery improve this outcome? The goals of total neoadjuvant therapy is to provide better compliance to chemotherapy, allow more downstaging, improve operability, reduce or delay metastases, and improve overall survival. There are 3 randomized control trials that have been, one in 2016 and 2 recently published, which have looked at total neoadjuvant therapy in different settings. The Polish study looked at locally advanced tumors. The Prodigy study is any operable cancer. Rapido study was again in loco-regionally advanced tumors. The Polish study randomized between short course radiotherapy FOLFOX4 into 3 versus long course chemoradiation before surgery. The Prodigy study in the chemoradiation arm give radiotherapy with capecitabine followed by TME with M-FOLFOX 12 cycles versus the experimental arm of giving M-FOLFIRINOX followed by chemoradiation TME and M-FOLFOX 6 cycles. Whereas the Rapido study, which has been published in full paper very recently, looked at first short course radiotherapy, then Capox into 6 cycles or FOLFOX into 9 cycles, followed by surgery versus chemoradiation, followed by surgery, followed by the same chemotherapy. The primary endpoints were slightly different. The sample sizes, these were moderate size, randomized control trials. What they showed overall was that there was a benefit in disease-free survival and metastasis-free survival by bringing up the chemotherapy before the surgery. But the difference in overall survival has not been demonstrated across the board. And there was a slight worsening of loco-regional control with the putting the chemotherapy in the middle. So this is what I just mentioned to you. So if I have to summarize, for rectal cancer, you do MRI for local staging, CT thorax and upper abdomen. If it's a CT1, T2, N0 cancer, then we do not offer neoadjuvant chemotherapy. If it is a T3 cancer with MRF negative, then our practice is still to, then you can, in selected patients, not offer neoadjuvant treatment and go into surgery. But usual practice is to give short course radiotherapy on neoadjuvant chemoradiation. If it is a CN2 or MRF threatened cancer, you can either give total neoadjuvant treatment or neoadjuvant chemoradiation. If you're giving neoadjuvant treatment, you are going to wait for 1 week after short course or 6 to 8 weeks, depending on your preference. And this would be followed by surgery. So the role of adjuvant chemotherapy has practically gone away with the total neoadjuvant therapy studies. So if you need to, for more advanced tumors, there is a benefit in giving the chemotherapy before the surgery as total neoadjuvant treatment. Now, if I have time, do I have time or should I stop here?
Sir, please continue, sir.
Okay. So a very quick look at anatomy. Now, this is a sagittal section of the rectum on an MRI, on a T2 weighted MRI. And as you can see that this is the rectum, it goes along the sacral hollow. And at this level where it turns is known as the anorectal angle formed by the puborectalis sling. And this is followed over here by the anal verge where, the anus opens outside. So the area below the puborectalis sling is the anal canal, and the area above it is known as the rectum. If you look at the CT scan, you need to appreciate the mesorectal fascia, which is, as you can clearly see in this image, is this fat-filled space with a clear boundary around it. And the entire mesorectal fascia is removed in surgery and needs to be covered in your primary target volumes in radiotherapy. MRI for rectal cancers is very important. I don't have time to cover all the facets of MRI-based staging. I would strongly recommend that the students attend this course, a free course on ncgeducation.in, very kindly provided by Dr. Suprita Arya and Dr. Shirley Lewis. And this is a course which I would say is recommended reading for any student who needs to understand rectal cancer. So just go to this website and enroll for this course. In terms of target volume delineation, there are international consensus guidelines on target volume delineation in rectal cancer now, which was published in 2016 by Valentini et al. In Radiotherapy and Oncology. I'll take you through a very quick view of the target volumes. So as you can see over here, the area in pink is the mesorectum. So this is compulsory for all patients. Alongside the mesorectum, which needs to come down right up to the sacral hollow, are the lateral lymph nodes, which are equally important. The posterior lateral lymph nodes, which are demarcated from the anterior lateral lymph nodes in the lighter orange color, by the level of the ureter. Okay, and further ahead from the the back of the external iliac vessels is the inguinal region. So if I external iliac and inguinal region, so this is how it starts at the top. So the nodal levels start where the common iliac vessels bifurcate. There is a presacral region in orange, and there are the lymph nodal regions, the external iliac region and the lateral lymph nodes, which are in red and cyan colors. So normally, the external iliac regions are not covered in rectal cancer. And this is an important difference from cervical cancers and prostate cancers, because these are not common areas of spread unless the lateral lymph nodes, so unless there are extra mesorectal lymph nodes, you do not need to cover the external iliac nodes. So your target volume will be restricted to the red area and the purple area for most patients. If for more advanced tumors, you would take the anterior lateral nodes, which are in light orange, and only if the lateral lymph nodes are involved will you take the external iliac nodes. Lower down, the external iliac nodes turn into inguinal nodes, and the lateral nodes also stop. And in low rectal tumors which have reached the sphincters and gone into the surrounding tissues, we will cover the ischiorectal fossa. Okay, so this is a very brief view into the rectal cancer target volumes. Now, these volumes are available at another website, which I forgot to name. This is the AROI project. I'm going to type over here. And I would recommend everybody, again, to enroll into the AROI project, which is it covers virtual anatomy for target delineation in all subsites of tumors. Now, in terms of radiotherapy planning, this planning is usually done in 2 phases, with a phase 1 of 45 grain 25 fractions or 4 weeks to the entire volume, followed by a boost phase of 5.4 grain 3 fractions to the gross involved disease with margins. We would recommend a high energy linear accelerator inside a pelvic target volume at all times. Usually, 3D conformal radiotherapy is done with a 3-field approach with 1 posterior field and 2 lateral fields. And IMRT is only beneficial if inguinal nodes need to be covered. There is a misconception that IMRT is important in rectal cancer. What is important in rectal cancer is good bladder filling, and if you have a good bladder filling protocol, then you definitely do not need any IMRT. So these are, example fields. So this is the posterior field and the lateral field that you can see over here. So as you can see from the field borders, the anterior field border is slightly behind where you would place it for cervical cancers because the external iliac nodes are not covered. And only a small part of the bowel, therefore, gets irradiated, especially with a 3-field field arrangement with posterior and lateral fields. And then we come to plan evaluation, where we would look at the coverage and we would look at the bowel dose. So the bowel constraint that we use is as per Quantec, which is a 45 gray volume of less than 196 cc. And with that, I am going to conclude today. I'm happy to take any questions.
Thank you, sir. Thank you. I am sure the PGTs will be much benefited from this class. It was an excellent class. So it's a bit over time, but I think we have a few questions. One is for I think this is for Dr. Biprodas. So Dr. Roy, are you listening? Dr. Biprodas Roy. So this.
Hello, can you hear me? I'm still there.
Yes, yes. Thank you, sir. So this question is, I think, someone Abhay Chakraborty has asked you a question. Shouldn't the resection margin for CO esophagus during esophagectomy be 10 centimeter? He's asking.
No. Because if you see one of my slide, I have mentioned, esophagus cancer we need a 5 centimeter macroscopic proximal margin. 5 centimeter macroscopic proximal margin. 10 centimeter margin we cannot afford in esophageal cancer.
So, thank you, sir. So I think another PGT or Dr. Jyoti, I think she had raised her hand. So if Dr. Jyoti is listening, she had raised her hand during the last lecture. Dr. Jyoti, I think she has gone offline. So Dr. Jyoti, you can ask.
I think we should go with the next question now.
Okay, so Abhay has another question. So, sir, this is for Dr. Mullik, sir. What should be the preferred interval between short course RT and surgery in C rectum?
So if you have a relatively small or early stage tumor, you usually operate within 7 days. If you have a tumor where surgery would involve either positive margins or it will involve an APR and you are still doing a short course, then you will give it a bigger interval. Because of the Stockholm 3 study, you know that there is no problem in doing that, and the downstaging chances are higher. So that is the usual decision making that we use at our center.
So, may I ask one question?
Sir, this is Dr. Anupam. Sir,
yes.
Indranil sir, this is Dr. Anupam here.
Yeah, tell me.
For the long...
Your voice is breaking, Anupam.
Anupam, your voice is breaking. Please post the question in the question and answer section and we'll read out.
Yeah, Anupam, you may type
Same
your
for long
question.
course and short course RT.
Anupam, it's not, your voice is breaking. So better you put the question in the chat box or question answer box. We'll read out.
Okay.
So,
I can type.
meanwhile, sir, may I ask one question, sir?
Yes.
Dr. Tanmay, yes.
Yeah. Go ahead.
Sir, I wanted to know in your practice, how, I mean, are you practicing the short course neoadjuvant RT? And if at all, then for, I mean, how much percentage of patients, and how do you?
We have been doing short course radiotherapy for a long time, and we usually choose short course radiotherapy for patients who have smaller volume disease and smaller or no nodal disease. So the reason why we could actually do short course radiotherapy for everybody. The reason why we don't do it is that commonly. So we would use short course radiotherapy in maybe 15-20% of our patients. So the reason why we don't do it more often is because we feel that, for the more advanced disease, it is better to give the long course chemoradiation, do the surgery, and avoid the adjuvant chemotherapy. Yeah, so with short course radiotherapy and surgery, there is no chemotherapy at all, both before and after. And that is not really well supported by the evidence that we have so far. So we don't have any hesitation in doing short course radiotherapy. And somebody asked whether the volumes are the same or not. The volumes are exactly the same. So there's no difference in the volumes between short course radiotherapy and long course.
Thank you. So this is a question regarding the G-Junction. So I think Dr. Tapesh Bhattacharya or Dr. Bipradasha, anyone can answer. So could you please explain the concept regarding the position of G-Junction tumor and its significance as elucidated by SIVA data?
Shall I take this question?
Yes, sir. Please.
Tapasda, hello?
Please carry forward. No problem.
Okay, because the G-Junction I could not cover in my presentation, So why the G-Junction is becoming so important for clinical oncologists? Because if you see the trend of gastric malignancy after that eradication of H. pylori, the distal cancer, the incidence is gradually decreasing all over the world. So what is happening? Proximal cancers are becoming more and more. Why? Because of the more reflux disease, more GERD related changes. So now the G-Junction is becoming very important for the discussion. Now, and another important thing about the management of G-Junction cancer is the lymph nodal spread actually can go in either direction. It can go upwards in the mediastinal lymph node basin. It can go downwards in the gastric lymph node basin. So what is the recommendation of managing the G-Junction so far? So as per the Japanese guideline, so if there is a tumor which is less than 3 centimeter from the true G-Junction, I will come to the point what is the true G-Junction later. So first, the evidence is if the tumor is less than 3 centimeter extending into the esophagus from the G-Junction, so the chance of involvement of the lower mediastinal node is high along with the perigastric node. So in that case, we have to clear the lower mediastinal group of lymph node during the gastric surgery. Now, if the tumor is more than 3 centimeter or more extending towards the esophagus starting from the G-Junction, in that case, there is a significant number of lymph nodal spread present in the middle mediastinal group of lymph node, which you cannot deal from the abdominal approach. In those group of patients, one operation I told you, that Ivor-Lewis esophageectomy, where we clear the mediastinal, middle and lower mediastinal group of lymph node below the level of carina. In those group of patients, we have to do Ivor-Lewis esophageectomy. Now, if the tumor is 4 centimeter or less into the gastric area, starting from the G-junction, in those group of lymph node, in this group of patient, you can do a proximal gastrectomy, keeping a distal stomach preserved. So proximal gastrectomy has its own advantage and disadvantage. Now, if the tumor is more than 4 centimeter into the stomach, starting from G-junction, we cannot preserve any gastric conduit or gastric lymph node, because this patient may harbor a lymph node in the infrapyloric and the suprapyloric, that is station 5 and station 6 also. So in this group of patient, we have to do a total gastrectomy. Now, what is the G-junction? The G-junction is basically not exactly the squamocolumnar junction. As per the endoscopy, the G-junction is a junctional area where gastric cell are present and the esophageal cell, means esophageal cell is both present. So the G-junction is exactly where there is something vessel called palisading vessel enter into the muscle layer. So it can be visible while doing the endoscopy. Endoscopists will say whether G-junction is free or not, where exactly G-junction is located, and accordingly we can guide the tube. We can plan, we can make a decision about surgical plan and treatment decision for the G-junction tumor.
Okay, thank you, sir. I think that answers Abhay's question. Any further confusion regarding that, Dr. Abhay? That's it. And the last question in the chat box that has also been answered by Dr. Indonesia. The volume for short course and long course RT for C rectum. Okay. So I think there are no more questions here to answer. So thank you all the panelists, thank you all the teachers. Very informative lecture today. Thank you all. So
Thank you.
Dr.
Thank you very
Anupam
much,
and Suranjan.